Good evening, everyone, and welcome to our webinar this evening from Benenden Hospital. We have a lot of people signing on to this tonight, so we'll just wait a few seconds for people to join. Right, a very warm welcome this evening to our webinar. It's fantastic to see so many of you joining. We've got over 200 people registered for this session, which is tremendous. So it's great to have you all tuning in. My name is Phil, and I'll be your host for this evening, and I'm joined by our expert presenter, consultant trauma and orthopedic surgeon, Mr. Matthew Oliver, who will be discussing treatment for knee osteoarthritis. And for those who haven't attended one of these webinars before, the format is as follows. The presentation itself will last around 25 minutes and will be followed by a question and answer session. And if you'd like to ask a question either during or after the presentation, you can do so by using the Q&A icon at the bottom of your screen. And you can do this anonymously, or you can give your name. And at this point, we should let you know that if you do give your name, the session is being recorded for archiving. If you would like to book your consultation after this session, then we'll provide contact details at the end. Now, before we begin the main presentation, I'd just like to mention that if you're interested further in the topic of tonight's webinar, we are hosting an in-person event on the 5th of June. This will be at Ashford International Hotel, and the event is titled The Robotic Revolution, Rosa and the Future of Joint Replacement Surgery, and it will feature Mr. Oliver and two of our other consultants, Mr. Alex Chipperfield and Mr. Raman Thakur, and they will be discussing the hospital's robotically assisted surgical system for knee replacement, more of which later, and the wider, rapidly evolving technology in the field of orthopedics. There will be opportunities for questions, buffet and refreshments just to increase the appeal. And if you are a member of our new loyalty program, My Benenden Hospital Rewards, you will receive 500 bonus points for attending that in-person event. So that's the 5th of June at Ashford International. Doors open at 6:30 p.m. There's information on the screen there. If you're within reach of Ashford, we'd love to see you there, and you can book your place by visiting our website, where you'll see a large banner on the homepage, and you can register via that link. And details on this event will be in your follow-up email after this webinar. That is quite enough from me. So without further ado, I will hand over to our expert presenter, Mr. Matthew Oliver.
Thank you very much, Phil. Good evening, everyone, and welcome. I'm going to talk to you tonight about management of osteoarthritis of the human knee joint. Included in this session is information about what osteoarthritis is, the treatment options, both surgical and non-surgical, information about the knee replacement itself and the patient journey that evolves when you have one, the risks of the surgery, and then quite a bit of time will be spent on the technology, especially talking about the robot orthopedic surgical assistant, or ROSA knee system. Benenden acquired this technology in December of last year, and it's up and running in the hospital now with increasing usage and success. We'll talk about recovery after knee replacements, and then we'll finish off with a question and answer session. So a little bit about myself. I was appointed a consultant orthopedic surgeon in 2010. My NHS base is East Kent Hospital, so I work at William Harvey and the Kent and Canterbury hospitals mainly. I'm a full-time consultant in the NHS. I started working at Benenden in 2012, and I solely specialise in hip and knee degenerative disorders in my elective practice. I've been on a reconstruction arthroplasty fellowship at the University of Calgary in Alberta, Canada, for a whole year, working for several renowned North American orthopedic surgeons. I perform double the national average of hip and knee replacements according to the National Joint Registry, and I practice at all times as much as I can enhanced recovery protocols to make sure the patient's journey is as smooth and as comfortable as we can get it. I've got specific interests or special interests in patient-specific knee replacements. These are sort of the predecessors to the robots. And in recent months, robotic surgery has been gaining momentum as a specialist interest of mine. So what is osteoarthritis of the knee? Essentially, it's wear and tear of the knee joint. Unfortunately, it's incurable and it creeps up with all of us. There are some risk factors that make people more prone to osteoarthritis than others, such as a previous injury to the knee, a nasty cartilage injury, or a ligament injury to, in particular, the anterior cruciate ligament. Even if this ligament is reconstructed, the biomechanics of the knee is altered forever, and therefore it has a propensity to wear out faster. Obesity, unfortunately, puts too much load on the knee joint and is strictly and closely linked to osteoarthritis, especially at the patellofemoral joint, which is a very weight-sensitive joint. Symptoms of osteoarthritis, the early ones really are just a bit of discomfort when you exert yourself. You find that your knee's a little bit stiff in the morning, but within a few minutes you've walked it off and it's okay. You can also have the sensation of a clicking or grinding feeling within the knee, and that normally comes from the patellofemoral joint. And it's caused by the cartilage fraying on the undersurface of the patella and on the top of the femur, so it's no longer a friction-free surface. You may notice that your knee swells up a little bit as well, but normally settles with rest and the occasional painkiller. As the condition progresses, the normal, healthy, shiny, glistening articular cartilage starts to fray and fissure and break off, especially in the weight-bearing zones of the knee, which are normally in the medial compartment. That's where the brunt of weight-bearing goes through the knee joint. About 70% of the force goes through the medial side. When that happens, it acts as a nidus for further wear, and the cartilage fragments, and eventually bare bone develops. At the same time, and slightly before this occurs, the meniscus or the shock absorber in the knee, you've got one on each side of the knee joint, that also frays and degenerates a bit like a washer on a tap. So therefore the cushioning and the shock absorbing between the femur and the tibia is diminished, and with every step you're literally tapping the femur on the tibia, bruising the bone and damaging the cartilage. This is when it hurts most of the time. And you'll be taking more regular painkillers and noticing a reduction in your activity levels and an avoidance of some of the things you used to love doing. When it gets really bad, the pain is there all of the time. It's at rest, especially at night. The knee gets very stiff. You find it uncomfortable to roll over in bed, and you notice that your knee is changing shape. It becomes a bit knobbly, and sometimes you develop what's called a bow-legged or bandy-leg deformity or knock-knee deformity. And in some cases, patients can get a knock-knee on one side and a bow-legged on the other. That's known as the windswept deformity. It looks like you've been blown from the side by the wind. At that point, the bad days usually outnumber the good, and you come to see an orthopedic surgeon. These are nice schematic diagrams of the human knee joint, basically going through the various stages of arthritis that I've just explained. And essentially it's all down to losing the shock absorbing ability that cushions the knee with every step. So the shock absorbers or the menisci perish first, then the articular cartilage frays, that then breaks off, and then eventually bare bone appears. And when bare bone and the cartilage have failed, bone touches bone, and that is osteoarthritis in a nutshell. The treatment for the condition can be categorized as non-surgical and surgical. Non-surgical management works quite well for the early to moderate arthritic knee, and that would be activity modification, avoiding the aggravating factors, weight loss to reduce the stress through the joint. Physiotherapy, interestingly, people ask me why physio is good if the knee hurts. It depends on the type of physio. It should be light load-bearing exercise and strengthening exercise. That definitely helps the arthritic knee. Moving the knee joint improves the lubrication of the joint and diminishes the discomfort. It also means that the muscles around the knee are able to stabilize the knee, and that can balance out the uncomfortable jerkiness or the sudden discomforts that you can get if you step on an uneven paving stone. Simple painkillers are helpful, such as paracetamol to start with, and then you go up the pain ladder with stronger analgesics from the GP, usually codeine based. Non-steroidal anti-inflammatories work well in the beginning as well, as long as you're able to take them. It's sometimes contraindicated if you've got asthma or you take certain medications or have some renal problems. Knee strapping and braces, there are loads on the market. Some of them are a bit clunky and cumbersome, but on the whole, in the early to moderate arthritic knee, they do have a role to play, especially offloading braces that can open up the knee joint so the two bones don't necessarily tap together quite so vigorously. Injections, there's the tried and tested steroid injection. I'm not a great fan of these. I say to my patients maybe up to 2 to 3 a year at the most, because the more injections you have, it seems the more counterproductive and the less effective they become. And they can also increase the risk of an infection if you were to proceed to a joint replacement at a later date. Other injections include viscosupplementation. This is a synthetic lubricant that's injected in the knee. It's not really a painkiller as such. It just reduces the friction between the two worn out surfaces. It works quite well in the early to moderately arthritic knee, but once it's more advanced, then it doesn't really work. These are the two injections that are available here at Benenden. There are other ones that are available at other places, but again, the evidence is not robust enough to offer them in the mainstream. The surgical options. The first one is to correct the alignment of the leg with what's known as an osteotomy. Quite crudely described, that means breaking the leg and resetting it again. You need to have very concise indications to want to do this, and the patient also needs to be very resilient and have full buy-in to the experience, because it's a lengthy recovery and usually reserved for the younger patient where arthritis is only minimal and there's a definite alignment issue. The idea is that the leg or the knee joint is realigned to offload the area that was getting worn. It does make subsequent knee replacement surgery at a later date a bit more challenging, because there's usually a metal plate to remove and the anatomy has been distorted. Arthroscopic techniques, that we have to treat the arthritic knee with caution when it comes to keyhole surgery, because we can make it worse. So in my practice, I think there's a lot to be gained from arthroscopic removal of a loose body. That's a bit of bone usually that breaks off, that can suddenly cause an uncomfortable knee to lock up or give way or become a lot more uncomfortable. When we whip the bit of bone out, the patient goes back to baseline and is quite happy with the situation. Also, unstable meniscal tears in an arthritic knee. There is a role to play to snip these out, but just washing the knee out for arthritis is a sham procedure and should be avoided these days. Microfracture, that's another arthroscopic technique. It's only really effective on small areas of complete cartilage loss. And you again, as the patient, have to have full buy-in, because you need to be touch toe or non-weight bearing on your leg for about 8 weeks while the fibrocartilage grows over the area that's been drilled with little with a little pick or a drill. Fibrocartilage isn't the same as articular cartilage. It's the next best thing, and it's not quite as robust. And again, the results are sketchy, really. I would certainly only do it on very minimal indications. Joint replacement, we'll talk about that in a minute. Cartilage transplantation, this is when you harvest cartilage from a non-weight bearing part of the knee and plug it into the worn out gap, and then put over like a glue or a fibrin clot over the cartilage, and then hope that it's taken by your own body and incorporated into the knee joint. It's been around for a while now, but it's only available in very specialist centres and also on a trial basis in the NHS. I don't think any private medical insurances cover this kind of transplantation, and it has quite a high cost to it, and it's not 100% signed off by the National Institute for Clinical Excellence, so it's not available in the mainstream. So the knee replacement is a good operation for full-blown end-stage osteoarthritis of the knee. We can also use it to treat inflammatory arthritis such as rheumatoid, but we don't see many of these knees these days because they're so well managed with medical drugs, the disease-modifying drugs. It can be used to treat a post-traumatic knee where a nasty fracture has damaged the joint, or if there's been a severe ligament injury, a more constrained hinge type knee can be used. The aim of a knee replacement is overarchingly to provide pain relief for the patient with some improvement in function and mobility. And also it can be used to realign the leg to a more neutral alignment to hopefully give a more sturdy gait pattern and a stable platform to stand. The population is changing. People are coming to us at a younger stage now, in their late 40s and 50s, with quite arthritic knees, usually as a result of sports injuries that have caught up with them or previous surgery to the knee. And they're still in the workplace and still wish to be active and play sport. So these patients need careful counselling about expectations following knee replacement surgery. It's a common operation. About 100,000 are performed every year in the UK. The average age in the National Joint Registry for a knee replacement is about 69 for man and woman. Most of the patients, just over 56% of them, are female. And importantly, it's pleasing to see that about 95% of patients report health improvement after receiving this operation. 80% of knee replacements do seem to be lasting for 20 years or more now, which is also quite pleasing. So here are the options available with regard to knee replacements. You have the partial knee replacement or compartmental replacement, where you go ahead and replace the worn out parts as they wear out. So you do the medial side, and medial unicompartmental knee replacements are offered here at Benenden, either the Oxford knee or the Zook knee. Again, I would recommend seeing a high volume surgeon if you're going to have this procedure. It's a niche procedure and it needs to be done with the right indications in mind, just in case there's progression of arthritis elsewhere in the knee, because that would lead to its early failure. Lateral unicompartmental knee replacement is very rarely done. It's a difficult operation to get right. And again, choose your surgeon wisely, a high volume surgeon for one of those. Patellofemoral replacement, very rarely done these days. About 1% of all the joint replacement, or of all the knee replacements in the UK, are patellofemoral replacements. Again, it has to be absolutely isolated patellofemoral arthritis. If not, it may need to be revised at a later date. So the partial knee replacement does work really well for a lot of patients. It's a less invasive procedure with a quicker recovery, but it does carry a higher revision rate. The total knee replacement, it can be performed with standard instrumentation or using computer navigation. Computer navigation has really now been superseded by robotic technology, as has the signature or patient-specific knee replacement. That doesn't use a computer in theatre. The signature or patient-specific knee replacement uses preoperative scanning of the knee, hip and ankle to produce a plan and then molds that are fitted to the bone. But really, they've been superseded now by robots. The constrained knee replacement is only really carried out when there's been severe deformity to the knee in a revision procedure, or if the ligaments have failed. So the workhorse knee replacement at Benenden Hospital is the Vanguard knee made by Zimmer Biomet. It's been around for a long while now, and it is the successor from the very successful AGC knee replacement made by Biomet. That knee replacement was removed from the market about 5 years ago, and a lot of the design features of the Vanguard are a big improvement from this knee replacement. It's performing well. It has an ODEP, or orthopedic data evaluation, of 13A, which means that 95% of them are still going strong at 13 years in validated survivorship charts. And in the National Joint Registry, I looked up the figures for this talk, and the 10-year revision rate for it, whether it's PS, CR, or patella resurfaced or without resurfaced, averages about 2.8%. And the same 15-year, the revision rate is 3.8%, which is very comparable to other well-known knee replacements on the market. It's usually cemented in place. So the consultation, you arrive for your appointment and have 20 minutes with us to develop the doctor-patient relationship, which is absolutely crucial for knee replacement surgery, because it's all about managing your expectations, making you aware of all the issues that are involved, because it is a painful procedure with a lengthy recovery time. You'll have a detailed history taken, a physical examination, x-rays and other tests may be required. It would be great to be able to give you an individualized management plan on the same day, but sometimes you may have to return for a follow-up if specialist images are required. If it's been decided that you are going to have a knee replacement, then it's all about getting you optimized for the big day. It's important to really get as fit as you can with trying to lose some weight, controlling your pre-existing medical conditions, especially diabetes. Diabetes is an independent risk factor for infection, and it has to be stringently managed. Prehab is a big buzzword in the last few years, especially with the enhanced recovery protocols. It basically means getting yourself physically fit, not just the leg, but the whole of you, ready to go for a big operation and recover from it. And it usually means taking gentle exercise, physiotherapy, visiting a gym. You'll have a pre-assessment appointment as well, where you'll have a full MOT with the nurse, and sometimes you need to see the anaesthetist to discuss your health issues in more detail. The journey really begins with the prehabilitation. Again, while you're waiting to come in for surgery, you're going to try and optimize yourself as best you can. All being well, you'll pass all of the tests set by the pre-admission team and come in for surgery. You come in on the day, you have a spinal anesthetic, and you're usually sedated. That means you're numbed from the waist down. You're closely monitored throughout by the anaesthetist and his ODP. And post-operatively, you'll be looked after by your own dedicated nurse. You have your own ensuite room, and you usually stay 2 nights. It is possible to leave after the first night, the following morning or afternoon, if you tick all the boxes and the physios are happy with you and you're medically fit. If you are medically fit, there's no benefit really whatsoever of staying an extra night in hospital. You'll be better off in your own home with your own creature comforts. It's important that you have confidence in your knee, your new knee, and weight bear fully on it on the day of surgery once your legs are woken up from the anaesthetic. The physios will see you twice a day. The rapid recovery protocol, it's all about making sure that your sickness and pain is well managed, getting you out of bed quickly and mobilizing you quickly so you have confidence in your new knee. The anesthetic techniques used these days don't just include spinal anesthetic, but several anaesthetists here use pain relieving nerve blocks around the knee, which can make your knee feel very comfortable indeed for at least 72 hours, or at least 36 hours after the operation, sometimes into day 2. You'll have x-rays, blood tests to make sure all is well. And after discharge care, there's a telephone service that you can ring into if you have any queries. The experienced nursing staff usually are able to answer those queries, and if they can't, they take a message and get in touch with your consultant. The risks of surgery. It's a big operation, so there will be risks involved, but they're usually quite rare. You can bleed, but it's incredibly uncommon to need a blood transfusion after a knee replacement. The bone can break either during the surgery or afterwards if you have a fall. You can get 2 types of nerve injury. It's quite common to get a patch of numbness over the knee, and that usually shrinks to the size of a 50p coin on the lateral side of the knee over the months that pass, and you don't really have a problem with it. The other kind of nerve injury is very rare, and that's known as a foot drop. It's when the common peroneal nerve is stretched. It usually recovers, but you'd need to wear a splint in your shoe while it recovers. Patellar tendon injury, incredibly rare complication, but a headache if it happens without the patella being attached to the tibia. You can't straighten your leg, so it has to be repaired. And when it's repaired, it means you keep your knee replacement out straight for 6 weeks, which unfortunately means the knee gets stiff, so you're going to have to work much harder on your exercises. Other risks, wound problems. You can get superficial wound infections, normally able to be managed with antibiotics and good wound care by primary care, but sometimes we need to get involved. And I always would like to know if there's an infection brewing rather than find out at the 6-week follow-up appointment. It's important that you engage with your surgeon if you've got any concerns. You can get a deep infection. The national rate of infection in the knee is about 1%. In Bennett Hospital, I'm sure it's much lower than that. This is a super clean hospital. But if you were to get a deep infection, we need to treat this rapidly and effectively. You would need to have the remedial surgery carried out in an NHS hospital with a multidisciplinary approach from a microbiologist, physiotherapist, orthopedic surgeons, and infectious diseases. Essentially, we have to wash the knee out and change any of the components that we can, the exchangeable bits, and give you really strong antibiotics for about 6 weeks. About 70% of the time that solves the problem, but in that other 30%, unfortunately, the infection comes back and more surgery is required with removal of the implants. The other risks include blood clots in the leg and the lung, stiffness and swelling, so it's no pain, no gain on the exercises, otherwise it will become a big peg leg full of scar tissue. I can't emphasize enough the importance of doing the range of motion exercises. It seems a game changer is lots of ice. You can use a pillowcase full of ice, or you can even use a cryocup device that you can hire or buy from Amazon, eBay, places like that. But that really does make a difference with pain management. The later complications are infection again. You can get an infection from another part of the body, such as your waterworks. It travels through the blood and lodges in the knee, or from a pneumonia in your lungs, but it's very uncommon and very bad luck. Eventually, the implants will wear out and fail. Unfortunately, people do fall over and break the bone around the implants, making them loose. Here are a few examples of some quite severe deformities. This is a varus knee or a bow-legged knee. Both of them are bow-legged actually for this chap. And you can see the corrective surgery on with the x-rays here, giving him a much more straighter alignment. Sometimes standard knee replacements aren't enough, and this guy here has got a very, very deformed knee. The left knee is swung right out into varus, and when he walks, he'll have what's called the varus thrust. And as you can see from the x-ray on my left-hand side, there's been bone loss, and the ligaments have been considerably contracted on the inside and stretched on the outside. That means that a standard knee replacement won't suffice, and you'd need to have a hinge, which is what you can see here on the radiograph. These are more complex operations and are not carried out on the NHS portfolio here at Benenden. Here's a picture of the rotating hinged knee. It's highly constrained. It's usually used for severe deformities, ligament injuries, and in cancer surgery. So the requirements for knee replacement include accurately restoring the individual's mechanical axis, an accurate bone resection. And if those things are achieved, it should hopefully give good functional outcome and a theoretical bonus of making the implants last for as long as possible. And that's when the ROSA, or the robotic knee replacement, comes into its element, really. Basically, as I mentioned earlier, the patient demographic is changing. Patients are younger, more demanding, want to carry on working in manual jobs, and also play sports and hobbies. And we have to manage their expectations. We're operating on a wider range of ages these days, from about 40 to 90 plus years of age. And the ROSA robot is a significant advance in knee replacement surgery, and it is here to stay. We can see it in other walks of life. If you look at YouTube and download what the Ocado warehouses look like, you see 30,000 little robots going around on this amazing tracker system collecting people's groceries. Or you watch a video of a car manufacturing plant, robots building cars. And even more recently for myself, in December of last year, when I went to Cologne to the ROSA head office, or the main training course, the hotel that I was put up in, there were robots delivering orange juice at breakfast and collecting plates. It just blew my mind. So they're here to stay. So the indications for ROSA, it's basically out there for anyone really who has an arthritic knee. But I think it really comes into its own when you have abnormal anatomy or significant deformity or previous fractures to the tibia and the femur where the alignment of the leg is altered. It makes a standard knee replacement extremely challenging, whereas with a ROSA, we don't have to worry about standard instrumentation. So how does it all work? Well, essentially, the robot is in theatre with us. It's our assistant. It doesn't do the op. We do the op. It just helps us optimize the variables that end up making the knee replacement. And how to get there is that we have to put trackers into the femur and the tibia. And then once these trackers are in, they communicate with the robot. And through real-time movement, we collect lots of data about anatomical landmarks, such as the center of the femoral head, the center of the knee, the center of the ankle, and also the bony anatomy of the knee joint. All that information is sent into ROSA's computer, and it designs a real-time model of the patient's knee. We can then put the knee through a range of motion and see the level of deformity and whether it's correctable. And we strain the ligaments on each side, the medial and collateral ligament, to see where the give is, where it's stiff, where it's contracted. All that information is fed back into the computer, and then a provisional plan is formulated. And you can see on the screen here, it's already fitted a knee replacement into this person's knee, and we haven't even made any bony cuts yet. This plan isn't set in stone. It can be adjusted and tweaked to the surgeon's preferences, and sometimes a little bit more bone is needed to be taken from the femur or the tibia, or the rotation of the implants has to be slightly adjusted to improve the ligament balancing of the knee. Once we're happy, we confirm the plan, and then ROSA really comes into its own. The surgical cutting guide is accurately placed onto the patient's knee and on the femur and on the tibia. If we move it out of place just a little bit, it will stop working and let us know. It has to be precisely positioned like the plan said so. Once it is, we fix it in place with a couple of pins and then cut the bone in the conventional way we would do a normal knee replacement. Once the bone has been cut, all the cuts are validated against the computer plan, and they're all extremely accurate indeed. They're all within a millimeter or half a degree from what we decided on the plan. Sometimes they're absolutely spot on to the plan. A millimeter here and half a degree there won't make much difference. It does make a difference if you're 3 or 4 millimeters out, and therefore you have the opportunity intraoperatively to adjust the cut if you were to be out of alignment. I think this might be a video. Is this the video, guys? Not sure if this is the video or not. Yes, it is. This shows us what happens in the knee replacement using the ROSA. I'm hoping it's going to work. It's about a minute long, and it just shows you main.
ROSA Knee is a robotic surgical assistant for total knee replacement. Your surgeon is specially trained to use the robot. ROSA Knee does not operate on its own. Your surgeon is in the operating room the entire time and making decisions throughout your surgery. Your surgeon creates a plan for your surgery based on your unique anatomy. The robot helps to ensure the plan is executed as intended. ROSA Knee uses a camera and optical trackers to know where your leg is in space. If your leg moves, the robot can tell and adjusts accordingly. ROSA Knee provides your surgeon with data about your knee. This helps to personalize your surgery based on your unique anatomy.
So there you go. In a nutshell, the whole idea is to give you an individualized, personalized knee replacement that is well balanced and with the implants optimally positioned to hopefully give you the best functional outcome and the swiftest recovery possible. And the early to medium term data from the ROSA Knee, where it's been used in institutions around the world, is looking very promising indeed. And that's why Benenden Hospital has adopted this technology, as have several other hospitals throughout the UK. Apologies for that. I'll just move it on to the next slide, hopefully now. This basically goes back to what I was saying earlier about the accuracy of the cuts. It provides highly accurate resections or bony cuts and improvement in the patient's limb alignment. And it reduces the outliers, basically. That being said, a standard knee replacement with conventional instrumentation, if done well with a high volume surgeon, there's nothing wrong with that. You'll still get a very good result, but this just improves matters a little bit more, makes things a little bit more accurate. So accurate component sizing, good positioning, real-time information on ligament balance and range of motion on the table, and everything is validated every step of the way to ensure that the preoperative plan is followed intraoperatively. If we don't like the plan, we can adjust. If it's going pear-shaped, we can abandon and go back to conventional instruments, but it very rarely has a problem. These are my colleagues that perform knee replacement surgery here at Benenden Hospital. And we all work together in the NHS. We're all colleagues and friends. It's a good team. So we're going to move on to the question and answer session now. Please feel free to ask me anything you like, and let's go for that.
Right. Thank you for all that insight and information. Quite a lot to digest there. So we'll take some questions from the audience. First question we have is from Alison, who asks, do you offer nuanced knee surgery for patients with patellofemoral arthritis? And what are the pros and cons of this?
Patellofemoral replacements do exist. As I was mentioning in the talk, they only account for a very small number of knee replacements done in the UK because the indications for them are very narrow indeed. You have to have truly isolated patellofemoral arthritis. Yeah, it can be replaced, the patella.
Okay, thanks. Next question is from Susan, who asks, is it true that after a total knee replacement, no one can continue to kneel, squat, to garden and wash floors, or sit back on your heels and sit cross-legged?
It's not an absolute contraindication, but it is uncomfortable to kneel on the knee replacement, and therefore most people before they've had their knee replaced are struggling to kneel anyway, so they don't mind to continue with that compromise. But if you had to kneel and you padded the floor out, I don't see that really being a problem. Squatting is all down to the range of motion that you get in your knee afterwards. You'd need to get at least 120 degrees, I think, to be able to squat. And to have the strength in your legs to hold the squatting position for any length of time. So that's down to rehabilitation of the patient, really. Cross-legged, no contraindications for me. If you can, then there's no reason why you shouldn't.
Okay, thanks. The next question is, will the use of a collagen supplement help before any knee surgery?
This is an interesting question. Anecdotally, I think there is some benefit from collagen supplementation. It doesn't just help your skin, your hair and your nails. It does seem anecdotally to be helping some patients, a bit like turmeric and glucosamine. That being said, I did read a scientific article recently that said that collagen comes in two forms, whole and hydrolyzed, and both of them don't really penetrate the joint. So it may just be a placebo effect, but in my own practice, I've seen people say that it helps them.
Okay, thank you. Our next attendee asks, I'm probably in stage 3 moderate osteoarthritis and I've been seeing a physiotherapist for several months. I'm interested in Durolane, as I've heard it described as an oil change for the knee, but not sure how to go about this.
So Durolane, if you're a member of Benenden, you're able to have one of these injections through your membership. And it's performed in the outpatient room under aseptic technique. Your knee is cleaned. And it's simply injected into the joint, and it's a lubricant. It's synthetic hyaluronic acid, and it's supposed to reduce the friction and hopefully reduce pain. In about 60 to 70% of patients with mild to moderate arthritis, I have noticed a difference. When the knee is badly worn, it doesn't really have much effect. If you're one of the lucky ones where it's effective, then the injection can be repeated a few times a year if necessary. Yeah, it's available for your membership. So please make an appointment.
Thanks. Next question is from Robin, who says, I'm 76 and damaged my knee during prolonged skiing in early 2023. X-ray identified mild osteoarthritis, but no bone injury or abnormality. I've managed the knee pain through physiotherapy and can now play golf again. I'm uncertain about surgical intervention. Any thoughts?
If you're managing your knee and you're having an active lifestyle, then there's no real need to go to the next step. But if you keep having setbacks and peaks and troughs, and you remain in the trough and the bad days are outnumbering the good, if the arthritis is just isolated to the inside of your knee, the medial compartment, then you may indeed benefit from a medial unicompartmental knee replacement, which is less invasive with a quicker recovery time. Certainly worth having your knee assessed by one of us to see if that's of benefit to you.
Okay, the next attendee says, I need a patient-specific knee replacement as I have a rod the full length of my femur I'm concerned that I need an experienced surgeon to do this. The rod has been in for 40 years. I'm not keen to have it removed. Do you have any advice, please?
Yeah, patient-specific knee replacement should be able to deal with this problem as long as the rod at the bottom part of the femur isn't too close to the bone surface on the front of the femur. Because if it is, when we make the cuts for the knee replacement, the implant and the saw may make contact with the bottom part of the rod or the nail. If that's the case, then the metalwork ideally needs to be removed. If that isn't the case, then the MRI, patient-specific knee replacement, would be a bit challenging because the metal in the rod would affect the scanner and the quality of the images. So you may have to have a CT patient-specific knee replacement where a CAT scan is done instead. Or alternatively, the robotic ROSA knee replacement, you won't need to have any scans, and that would be able to, all being well, leave the rod in place as long as, I say, the rod isn't too far down in the bone and too close to the edge of the top of the femur.
Okay, thanks. We have a second question from Alison, who asks, can 2 compartments of the knee be replaced instead of a total knee replacement if the other compartment is normal?
That is a possibility. It is practiced in a few units around the UK, and I saw it on occasions when I was on my fellowship in Canada back in 2009-10. When you have each part of the knee replaced as it wears out, but you have to bear in mind that it's an operation each time, and with every operation there's the risk of introducing infection and also post-operative stiffness. So you just have to bear those factors in mind. It might be better to have one operation done well once.
Okay, thank you. We have a question from Carol. Bear with me, it's quite detailed. I had total knee replacement in June last year. My knee is hyperextending and is now unstable and making walking difficult. I've been advised by 2 surgeons that revision surgery with a hinge joint should improve matters, but I'm reluctant to have more surgery, but know things won't get better without. The alternative is to wear a brace, but the new surgeon doesn't think a brace would be a good idea. Should I seek another opinion, and how do I find a specialist revision surgeon?
So if your knee is unstable and 2 different surgeons have advised that revision surgery is a sensible option, then it sounds to me that a hinged or fully constrained knee replacement will remove that instability for you. This is specialist surgery because it would mean the old knee replacement would have to be removed. It is a brave step for you to take, but of course, if you were to leave things as they are, it will most likely get more unstable and you'd be at risk of falling. To find a revision knee surgeon, you need to go to your local NHS trust, or you can have a look online. But most large NHS trusts now have a revision hip and knee teams. The one I work for in East Kent certainly does, where there's a multidisciplinary team and all the cases are discussed and the best plan is decided on an individual basis.
Okay, thanks. We have a question from Malcolm, who says, I've moderate peripheral arterial disease in both legs. I've heard that this may be a complication in knee surgery where a tourniquet is used to reduce blood flow.
Yeah, that's correct. So if you did require a knee replacement, it is slightly higher risk. So it is best to do your knee replacement without a tourniquet. And that's quite widely practiced now. A few of my colleagues at this hospital don't use tourniquets. And therefore there's no risk of any trouble to your peripheral vascular tree because the blood supply is left to flow throughout the case. It just means that the surgeon has to be extra specially vigilant with stopping the bleeding and increases slightly the risk of needing a blood transfusion afterwards. But you can do a knee replacement without a tourniquet.
Okay, thanks. Mike asks, how much flexibility does a knee replacement have compared to a normal knee?
Well, a normal knee without any arthritis should have a range of motion from 0 to about 140 degrees of flexion. So that's when you bring your heel right back to the bottom of your buttock. So you're sitting on the floor with your knees fully flexed. When arthritis goes into the joint, it stiffens up. And sometimes the preoperative range of motion is a very good indicator about as to how much post-operative range of motion you'll get. So if you start off with a knee that only bends to 90 degrees and you can't extend it, so it has a fixed flexion deformity, then your knee replacement will hopefully get your knee out straight, so the fixed flexion will be dealt with. However, the flexion, we'll be lucky to get it more than about 105 to 110 degrees. So it all depends on the preoperative range of motion. And unfortunately, in a few cases, people have an adverse reaction and develop lots of scar tissue, and the knee is actually stiffer than the knee was prior to having the operation. But that's very few and far between.
Okay. Emma says, is there a BMI that you need to be under in order to be considered appropriate for surgery?
At Benenden Hospital, the BMI cutoff is about 40, I believe. And you need to be otherwise medically very fit as well. In the NHS, the BMI in certain hospitals is a bit more flexible, but I think a BMI of 40 or less is what you need to aim for.
The next person asks, I have varicose veins. Is this an added complication?
It shouldn't be. Again, the large varicose veins are very easy to see and will need to be tied off if they get cut during the surgery. And they're quite superficial varicose veins, so we can either skirt the incision around them or they'll move out of the way. But if they're directly in the way, then the surgeon will tie them off and carry on as normal. So it's not a contraindication or an added complication.
Okay, thanks. Diana asks, after total knee replacement, can a person walk up and down stairs normally again?
Hopefully, it takes a bit of time, but yeah, you should be able to go up and down the stairs normally as long as the knee is stable and your pain is well managed. It does take a bit of time though to learn that again.
Okay, this next attendee asks, will the osteoarthritis always progress to a worst case scenario, or can it halt and not get worse?
Unfortunately, it is incurable and will gradually get worse, but the timeline is really variable. Some people can soldier on with quite absolutely shockingly arthritic knees, and some people, their pain management or pain threshold is lower and can't tolerate it. But unfortunately, there is no cure at the moment. All these novel therapies that I mentioned earlier temporize the affair, slow it down or make it more manageable for the patient. But in the long run, no one can stop it from progressing.
Okay, thanks. Next person says, I'm having steroid injections which ease the pain and grinding as the knee is not deemed bad enough for surgery. How long should this continue and how many should be given?
In my practice, I don't recommend any more than 2 to 3 per year, and eventually the injection will become less effective. Once it becomes less effective, then it's best to get reassessed for fresh x-ray and examination, and then perhaps think about the next stage.
Okay, thanks. This next person asks, I've had an operation for my cruciate ligament when I was in my 40s after doing it when I was 11, damaging it. I'm having severe problems now, very swollen, and problems with the back of the knee. Would a knee replacement help?
I think it's definitely worth touching base with an orthopedic surgeon to have a thorough history and examination and x-rays and maybe an MRI scan. And then we'd be better positioned to see whether we can help you with a knee replacement. I certainly wouldn't recommend a knee replacement if the articular cartilage was still reasonable and you didn't really have too much bone on bone. If you do the knee replacement too soon, then the results are usually quite disappointing. That being said, if the knee is grossly unstable, then perhaps the knee replacement, a more constrained knee replacement, is an option. You need to get seen by one of us first, really.
Okay, Helen asks, I'm bone on the medial surface. I've been fitted with an offloading brace, but this is of little effect and I need crutches to walk any distance. I have a locking sensation throughout the day and at night. Am I at the point of needing a total knee replacement?
Again, it's worthwhile making an appointment to come and see us so we can examine your knee and x-ray it. And if it's just isolated to the medial side and the correction is the bow-leggedness or the varus correction is possible, and your cruciate ligament is intact and the arthritis elsewhere in the knee is minimal, then half a knee replacement might suffice. But if there's wear and tear elsewhere, if the deformity is fixed, then a total knee replacement is the thing to do if the bad days consistently outnumber the good.
Okay, next question is from Emma, quite a common one that we get in these webinars. I need both knees replaced. What would be the timescales between operations?
If you're super fit, they can both be done at the same time, but very rarely these days. I haven't done that for years. I personally think it's best to do it in a staged procedure with a minimum of 4 months between each one.
Okay, thanks. The next person asks, why do you think a washout is not a good procedure?
In the New England Journal of Medicine, which is a very high impact factor medical journal, a large meta-analysis was done about the effectiveness of arthroscopy of the knee in the presence of osteoarthritis, and the overall conclusion, statistically significant conclusion, was that it's a sham procedure, just going in, washing out and coming back out again. It might give you a few weeks worth of relief, but the risks of the anesthetic and the complications that can happen to the knee, such as a blood clot or infection or bleeding, far outweigh the benefits. And from a health economics point of view, it is also wasteful.
Okay, thank you. I think we've unfortunately run out of time for any further questions, and I'm sorry if we didn't answer all your questions. As you can appreciate, we had quite a high attendance for this, and we've made a small dent in the questions. But if you've provided your name, we can answer your question via email, or if you're able to attend our in-person event on the 5th of June, you can ask your question in person. If we just move on to this slide. So as a thank you for joining this session this evening, we are offering, as it's listed on the screen here, 50% off your initial consultation using the code listed there. You will have a callback from your dedicated private patient advisor, and you will receive an email tomorrow with a recording of this session and updates on news and future events. And if you'd like to discuss or book your consultation, our private patient team will be here till 8 p.m. to take your call this evening, or between 8 a.m. and 6 p.m. Monday to Friday, using the number listed on the screen there on your right hand side. And you'll receive a survey when this session closes, and we'll be grateful if you could fill that in. Your feedback obviously helps us to improve future events. Our next webinar is on breast surgery, and you can visit our website to sign up for that. And all that remains for me to say is, on behalf of the team here at Benenden Hospital, I'd like to say thank you for tuning in today, and we hope to hear from you very soon. Thank you and goodbye.
Bye-bye.